All right, welcome back, everyone. We're here on session 4. Fide is just going to quickly do the housekeeping.
Okay, so these are just a few housekeeping items to keep in mind for today's session. It's basically the same instructions, that all participants are muting upon entry. Make sure to engage in the chat if you have any comments or any suggestions, or if you would like to provide your responses to any of the questions that we're going to be going over. Raise your hand if you would like to unmute. This meeting is being recorded, and the slides and recording link will be sent via email as well. This is just a kind reminder to everybody that NCHPH is supported by the Health Resources and Services Administration and is a national training and technical assistance partner and is 100% financed by this grant. And the information presented today are those of the author.
All right, everyone. Welcome. Thank you for coming back to the last session of our series. Last time in session 3, we reviewed how to integrate questions regarding cultural background into screening, and in particular, the complexities of doing so. When we did that, it reviewed the, at times, impractical nature of certain screening tools, but the built-in flexibility into many of the tools as well. That allows the addition of important questions that are often omitted from those tools, including the patient's cultural background. We went over at times some trepidations to altering tools, but to be sure to stick to your policy guidelines at your facility, and to make sure you practice this before you try it on patients. And in our last question, we looked over ways to inform yourself cultural diversity in your community and at your facility. So let's go on to learning objectives today. This is going to be another case-based study. We're going to be going through a difficult case, and we are going to be breaking it up into different aspects of the case that are cultural barriers. In each step, in each transition, I'll give you a series of questions to consider the cultural complexity of the patient's situation and how the provider would navigate it. I know everyone here is not clinical, so if there is something that pops up in the question that is relevant to your position but is not necessarily clinical, that doesn't make it any less valuable. In fact, I would love to hear that diversity in our responses today, if anyone has some unique perspectives to this, depending on what your role and responsibility is at your facility. So that's what we're going to be doing. Then we'll go over to some light review of some of the takeaways, light reviews of some action points you can put into your own practice, and say goodbye, high five, and go on with the rest of our days. So next one. And next one. Okay. So just to go over the format here, this is a case that's going to go over 4 slides. Each slide is a segment of a clinical encounter between you, a therapist at a rural health center, and a patient that was referred from her primary care physician for behavioral health. In each section, I'm going to read the question, give you a couple minutes, we'll get a couple of answers, discuss any complexities that come up, and go on to the next one. Okay, so I'm going to read it real quick. Oh, do we have any questions before I proceed? Okay, moving on. You are a therapist. Oh, and if anyone has if they prefer to write things down for this, which I would recommend, give you a second to pull some things out or pull a Word document out. You are a therapist working intake at a rural health center in Texas. A 21-year-old female presents for her first behavioral health therapy appointment at your facility. She was referred from her primary care physician. Besides her last name, Martin, and diagnoses, both anxiety and depression, you have no identifiable information about this patient. All you know that is on first appearance, she demonstrates closed body language and has a neutral facial expression.
Okay, so for the first question, we have, how will you identify this patient's cultural background? And the second question, how might this information be relevant to her treatment?
Starting timer.
All right, so we're going to provide 3 minutes for you to think about the answers.
Peter, do you have a timer going, or do you want me to put one up?
Yeah, I already turned it on.
Thank you.
Okay, time is up. Do we have any volunteers that you would like to provide your responses? Let's start with the first question. Okay, so I'm going to start calling on Abira. Do you have a response for the first question? And when you provide your responses, if you can just, give a brief introduction about who you are, what organization you're joining us from, and what is your title. Okay, so Ana Maldonado, do you have any responses?
Okay, yes, good afternoon again. I keep
Good
getting confused.
afternoon.
My name is Ana Maldonado. I work for North Texas Area Community Clinic here in Fort Worth, Texas. It's a federally funded clinic. So we do have at this particular clinic, we have a large Hispanic community attending here because we are one of the ones that do see individuals who are underinsured here. My role is, like I mentioned, case manager behavioral health case manager.
Mhm.
So on question 1, I just went back to what was said earlier. At one of the webinars, one of the classes is, instead of trying to guess, maybe go ahead and ask the patient. Because I remember you had mentioned that guessing can kind of be incorrect. So just actually approaching the patient and asking them a little bit about their cultural background. So that way it would give me some insight to their background there.
Mm. I appreciate your response, Anna. So 100%, the guessing process at times can be an imposition. The best way is just to ask. Specifically, if you're in a situation when your facility does use a standardized screening procedure, with some do, and actually on a facility level, it's something that I would recommend. It provides an ability to train. It provides an ability to bring things into the conversation. And if you're approving a use of a screener from the top, it gives you a lot of flexibility in controlling the conversation in the exam room and making sure your patients are getting the best care. So something, if your facility hasn't talked about, I'd recommend you consider talking about. But the guessing is in a way an imposition, and the best way is just to ask, even questions that you might think have obvious answers, because at times what we think is an obvious answer, there may be a complexity there in the patient's life that we don't know about that's particularly sensitive. So appreciate that. We'll do one more if you don't mind, Fide.
Yep. Okay, so Joshua, would you like to participate?
Sure. I mean, for me, one of the things that I was thinking about was I was just going to ask the person if she could tell me a little bit about herself and, why she would find herself here, not whether or not she wants to be there, but why she would find herself there, and just open it from there. Because, the closed body language and facial expression might be due to lots of different things. It might be due to the fact of, and I'm just going to put this out there, the fact that I'm a male. And, she might not be comfortable with the fact that I'm a male. I know that doesn't directly talk to cultural pieces, but, this kind of example is something that I actually have to deal with almost on a daily basis. So, 9 times out of 10, I find myself just asking, okay, so why do you find yourself here? And, sometimes wrapping their head around how I'm positioning that question takes about 30 seconds. But it really just puts it in their lap, and they can, whatever they respond with that question is usually telling me whether or not it's going to work. And maybe also from just the information in that question, I'll find out maybe I'm not the right person to be in that room with that individual. Making sure that, that person has somebody that they might feel more comfortable with. So that's how I took that.
Joshua, how long have you been practicing for?
About 12 years.
Okay, that's what I
13
would
years.
have guessed, something up towards a decade, because you're speaking from the perspective of a very experienced clinician. And I went through a transition in my training, and I've seen this in about depending on the field, when you gain more experience, really being able to tie in understanding key dynamics of the patient and patient's background into just the rest of the questioning that you usually do, and especially into things that you find de-stress the situation. So if you can do that and you can integrate that into your process, that's a goal for everyone. But for those of us who don't have a great process yet or are working through it, having a standardized tool in your mind can be a good way of providing I like to think of them as scaffolding for building your own repertoire as a clinician of how you approach difficult situations. In many medical situations, and this is from the perspective of someone who trained in psychiatry and internal medicine throughout residency, the things are often a lot less straightforward in behavioral health than they are in, say, the ICU. Actually, those are the two sides of the spectrum of how complex I think different medical fields are. And when we're in the ICU, everything is algorithm based. If you're going into a situation, there are two possible outcomes, and you choose based on what you see in front of you. I really struggled during some of my psychiatry rotations because there was a completely different way of thinking, and that your patients' lives are so complex and you see so many of them that it's difficult to think of all your own standardized procedures when approaching these clinical situations. And what I recommend to do is exactly what Joshua seems to do, is have a process that works best for you, and take your time to get feedback from what you see in your patients and your colleagues. And eventually you'll be able to tie the important questions into a narrative that makes the patient feel accepted. And that makes a huge difference in follow-up, as I'm sure you may have noticed. So I appreciate that. And if we could do one for question 2, please. And we'll do, yeah, let's do 2 minutes on that, please, Fide.
Sure. All right. Kiana Woods, do you have a response? Thank you so much, Joshua, for your feedback.
My bad, I thought there was a break, excuse me.
Yeah, so for the second one, so after I've asked them about their cultural background, how they identify, because like even with maybe even it not just being ethnicity, but maybe there's other little subcategories within social construct that you identify, I could possibly relate to them a little bit more, and maybe even by knowing their background might know or learn about maybe possible taboos with talking to a therapist and within their cultural background. That's how I think it would be relevant to the treatment, knowing how to approach them about certain subjects, and then also finding a common ground possibly too, to talk to them so they'd be a little bit more at ease with me.
So I really liked what you had to say about this. In particular, what you had to say about social identity. And the reality is, there aren't many things that are more complex than a human being's identity. It's incredibly complex. And even though in certain aspects of someone's identity, their culture, their race, their gender, you may not be able to relate to it directly with your experiences, I bet you there's something there. So it's really just, I've never not been able to find it. I've been taking care of patients with different race, different religion, different culture, didn't speak my language, and connected to them on parenthood, or on being a father, or taking care of children, or having an elderly relative. There's always something that you can connect to someone with. And that's not just a fun fact. When you are having a conversation with the patient, in a way, it's kind of a negotiation. And I not to make it overly transactional, but there is plain and simple power dynamic there that's difficult to ignore and very difficult to navigate. The more you understand, I feel like the easier it is to navigate, and the more careful you can be. And those little parts of our identity that help anchor us together are important parts of that process of being able to get the patient to agree to open up and agree to allow themselves to be cared for by you. So I appreciate that. Thank you. Move on, Fide, unless anyone's hungry to share.
Okay, thank you so much, Kiana. We're gonna move on to the next.
So, wait, hold on right here. Hold on. So we get key parts. Just narratives are complex. And a strategy I use is to find the important things that I know are going to be in. They're really, you're finding data points in a way. And if you have a set goal as a behavioral health worker, whether it's linking the patient to care or completing a session with them, finding the right data points is important, or you'll find yourself overwhelmed by the amount of information that's being thrown at you. So patient's age, and these are all the things. We don't need to review them, but those are the things that popped up for me. Next slide. Oh, wait, 1 second. I think I have some notes here. Yeah, so some notes on this. To the barrier that's clear when you enter the room with a patient like this, regardless of your race or background, even if you have the exact same demographics of the patient, there's still a power relationship in that exam room that really can never be totally ignored. So there's always some sort of barrier. How big it is depends on a lot of factors. But in general, minority and disadvantaged groups experience disparities throughout the entire spectrum of the behavioral health system. From intake to outtake, every interaction they have is a potential point of friction, and a place where they experience disparities. So just keeping that in mind and keeping in mind how important your link is within that chain to improving the patient's experience, and how multidisciplinary it is. When you're taking care of a patient, multiple your colleagues are as well, through their intake and through their processing or whatever job they may have. So this really is a team effort. And the trends in insurance coverage and economic trends in our country make it difficult to imagine a world where this gets much better in the near future. So these are things that we will repeatedly need to deal with, possibly throughout our careers. So next, please. Okay, so this is the same patient. Next step. Per your facility guidelines, you perform a prepare assessment and include questions regarding cultural background. The assessment reveals the following information. Patient's a resident of your community and lives with her parents. She works part-time at a local grocery store. She appears confused at first by your questions regarding culture, kind of like when Joshua mentions it takes 30 seconds to answer, something like that. When you re-clarify, she notes that both her parents are from Mexico, that she was born in Texas. Patient speaks Spanish at home with her family and is English fluent. She has a high school diploma. So with this step of our interaction, how will this information impact your interview of the patient? And by that, I mean the bullet points. And if you were to ask one follow-up question based on these bullet points, what would it be? And if you can provide us insight into why, I'd appreciate that. So we will take, we can take 3 minutes on this, Fide, and then here we go.
Okay. Okay, so time is up. I am going to select one participant now. Ken and Care, would you like to provide your response to the first question? Okay. Luz Colon. Remember that if you're not able to participate verbally, you can also provide your answers through the chat. So again, Joshua, would you like to participate?
I can. So, for me, again, maybe I'm being too generalized, but, when I'm looking at this information, the first thing I think about is this is all information about home. So I would probably open a question up with, can you tell me what it's like for you while you're at home right now? Tell me a little bit about that. Not because I don't know enough, but because I feel like if I talk about the things that she probably identifies the most with, she'll probably open up more willingly for the full assessment. So that's probably where I would go first.
And I agree. What we have here is a patient that has some very serious concerns about coming here, and it was probably a close call for her even showing up today. Her body language is still closed, but you are getting information from her, and that provides you an opportunity to connect. So this is something that this stage in the interview represents, the opportunity to connect further with the patient, and if she'll allow you, to help her open out. And that sort of reminds me of the power imbalance here is one of the aspects of this part of the narrative is in the exam room or in things that feel like an exam room or feel clinical, there's an immediate power disturbance between the one who's seen as clinician and the one who's seen as the non-clinician. The built environment, your body language, and who you are, how you talk can help to bring that barrier down, but it's never gone completely. So the good thing is it's complex and there are a lot of things that apply to it. So keeping in mind that that's something that can be brought down to a manageable level just by how you connect with a patient and how you talk to them. There are some circumstances though where you're not going to be able to give the patient the care that you think they deserve, and that's the time to ask a colleague to help you out. And the good thing about most of what we do in behavioral health is it's not as rigid as in other parts of clinical care. Things are flexible, tools are flexible, and follow-up is flexible. So there is space to accommodate different cultural groups. The question is, can you find the space? And always ask what a patient's preferred language is. It oftentimes can be different than what you assume it is. So if we could do another one, please, Fide.
Yep. Okay, Anna, do you have a response?
I think for me, it would help me because for me, I am Hispanic. I am first generation born here, so it would help me connect with her a little bit more. I would also ask her, how is it in possibly how her family thinks about her coming in here, and if that's causing any problems for her, if she would want to try to talk about that.
Anna, I have a follow-up question for you. What this gives you the opportunity, so this is, in this case, you'd be very well designed for this patient from a cultural background perspective, because you feel that you have something that you share with her. And that's one of those linchpins that helps us to get the patient potentially to open up or to at least understand them better. But when you're specifically with this patient, when you find that you have a cultural similarity or any similarity that you're using in this way, what are the ways that you use that to bring the narrative forward? And if you don't have a specific answer, that's fine. I'm just interested to hear what your perspective is.
No, I don't really have a specific answer. I don't really do counseling. I just do more of case management. So just to helping them connect with the therapist. But I try to, like in this narrative, I think I would be, for me, I've noticed that I'm more comfortable in this situation because I do go back to English, Spanish speaking. And sometimes it seems to help the person because you're able to, what you can't communicate in English, you can say it in Spanish. And sometimes for me, I think it helps me a little bit, help the person feel more comfortable. I think that by me being able to talk both languages, for me, I think it helps them be able to connect with me also. I try to make everything very simple, informal, more of a friendlier talk with them. Once they get to the therapist, then they're able to communicate a lot better. I just try to see what it is that they're having problems with, whether it be a child or depression, just simple stuff like that. I don't really haven't gotten into all of that, and I'm not going to go all that, but all this I think does help me prepare the therapist for their counseling. I hope that answered it. I think I went all the way around.
Went into like a long list of things I wanted to ask you about, and it's actually great that we have someone in your specific job here, because when we're talking about that link of we're all a multidisciplinary team, and from intake to output, we're all passing off this care of this person depending on what we're doing. Yours is really important for that because you're in a way the first clinical impression that they have. If I'm putting you in the right part of the chain, and at the very least you're an early part of it, and the impression that the patient gets or how they feel from you could very likely impact the next stage in that chain pretty significantly. So it's a big opportunity to make things better, but also it's not an easy place to find yourself in regularly. It's a difficult, as I'm sure you could tell us, difficult thing to navigate. And you mentioned English and Spanish. This is something that I struggle with a lot. And I'm not sure if you have I think we've talked about this, Fide, you might have an opinion about this. But considering the great diversity of countries that people who speak Spanish in the United States come from, I really struggle to understand how you can make those connections because it's so vast, and how the language helps with that.
Well, so far I've been really lucky because most of the people I have spoken with over here are mostly from Mexico. I don't really have a lot of Central America or South America individuals. So that helps me a lot because I'm able to connect with that. But even from Central America, anywhere else, just for me, like I said, especially if it's first generation born here, I think a lot of what I was raised with, a lot of those culture habits and traditions still continue. So like when you pointed out that she lives at home, you speak Spanish at home, but you're fluent in English. So a lot of that is already what I'm already used to. So I think that helps me a lot because at home, when I was at home, I did speak only Spanish to my parents. And even now when I go back to them, I think for me, that's a plus because I'm able to connect. Luckily, I do work in an environment where it is majority Hispanic, Mexican individuals, so I'm able to connect, and I try to make them feel comfortable at ease because a lot of times they are worried about coming in here. So I try to relate to whatever they speak about.
Excuse me as I find my charger here. Just a very quick response to that. And what I'm hearing is it's a complex visualization, really. All of these factors allow you to put yourself in the patient's shoes and to understand her perspective better. I appreciate you sharing it. If we could go to the next slide, please.
Thank you so much, Anna, and everybody else.
Oh, Pete, did you have any thoughts on that? On connecting with Spanish speakers from different origin countries? Is that a barrier at times?
Well, based on like my work background, I used to work at dental clinics for like many years, and a lot of times it was always helpful for me because I just spoke Spanish. So for me, it didn't really matter whether they were from Mexico or from Central America or South America. We just had that common language. So it was very helpful for them to like come into the office, into the clinic, and then explain to me things in Spanish, and then just being able to also communicate that with the doctors that were in the clinic.
Mm-hmm.
So I guess it just depends on the situation. I think, being able to have somebody that speaks the patient's language in like a clinic, that is always helpful too. So.
Yeah, I appreciate that, Peter. It is also a civil rights issue. So patients have a legal right to that. I think it's either the Civil Rights Act of 1964 or 69, maybe. That was integrated. I'm not sure how it was integrated, but it was something related to standards in clinical care, and it was placed there. So it's something that we need to take very seriously. And not just what languages they can speak, but what languages they want to speak. I don't know if you've ever met someone when they've had a head injury or had a stroke, but often one language just gets turned off. So that can happen. So listen to what they have to say. Next slide, please. Is this it? This is the next slide. Okay, yeah, next one after that. So you follow up asking more questions about the patient's cultural identity in an attempt to either connect to her or figure out if this is a barrier that you're facing. What you find out is her family has been in the US for approximately 25 years. Parents speak limited English, both work full time. Nobody in her family has ever attempted therapy. Her parents do not know she's there at the moment. After continued discussion with the patient, you find out that she was initially resistant to seeing a therapist, but was convinced to do so by her physician. When asked what changed her mind, she notes that she didn't remember. Despite your attempts to connect with her, you notice her body language remains closed, and she continues to offer only terse, sharp answers when you ask her questions. So here's my questions for you. How can we improve this patient's experience? Either things we're going to do or things we should have done. And two, what alterations to this patient's care could lead to an improvement? And that's in the steps that we could do next. Okay, and we'll take 3 minutes, please, Vida.
Yep. Okay, so time is up. Do we have a volunteer for question 1?
This is my favorite question. I feel like we need to pick Joe for this one.
I was just gonna volunteer, even though I'm like literally.
I saw you with your.
I've only been in this meeting 10 minutes, so I missed all the wisdom you already gave to everybody, or everyone shared. So I mean, the only thing came to me is I think I would ask about what role she plays in her family. Like, what do her family members look to her for, or what does she enjoy doing for her family? And try to connect with her values that way, or with her friends. Like, how would other people describe her? And then try to get a sense of maybe what's been missing, like, what's keeping her from maybe being like that. I have no idea if she's coming in depressed or anxious or anything, but that's the only thing that came to me.
Yeah, I mean, here's the situation. There's something's not working, right? Patients still exhibiting closed body language, and a lot of things are that we express are vary from culture to culture. I feel like body language is something that's fairly uniform at times, especially with stress when people are showing closed body positions. I've seen that in almost every country I've been to, and almost every culture I've interacted with. To see that is pretty widespread, I would say. So this is a problem, and the question is, what do I do? Am I going to be able to fix it, or do I have to pass this off to a colleague? And those next questions get you to that. Thank you. Fide, if you could pick another, please.
Yep. Abira, would you like to answer to the second question? No? Okay. All right. Kayana Woods?
Okay, so for the second questions, I was thinking that after maybe getting her to talk a little bit more about the things that she's interested in, to get her at ease with talking to me, maybe try to find a different approach to not sort of force the hand. Like she said, she didn't remember why she came here, and she is a little uneasy with therapy. Start off with soft subjects, things she's interested in, talking about herself a little bit more in her day-to-day life, so we can get to where we need to get to. Because I want her to be comfortable to come back to a second session. And if she's already on the fence, I don't want to push the issue too much.
I like to think of the continuity of care as like a chain, from intake to outtake. And this transition right here, and each time we go to a different player, we're going to a different link in the chain. One of those links is when the patient comes up for a follow-up or a second appointment at your office. And I find that that's one of the links that has the most friction. It's one of the places where the patients are most likely to drop off and not get care. And the question is, how do we traverse that? And sometimes we need extra information to do that. For someone in my situation, I don't have really much to overlap demographically with this patient. If she was continuing to show this body language at this point, I would think maybe there's a colleague that may be more appropriate for this, and that it's time to pass off care. Because for me, I don't think I could traverse this barrier effectively in a way that's in the patient's best interest. And sometimes it's difficult to say that to yourself, but the thing that matters is them, not necessarily how you feel about it. And that's an important thing to remind ourselves as we're going through these. These difficult situations come up every day. And the question is, how are we going to confront them? So anyway, moving on, could we go forward to one slide, please? And just the important parts of the narrative that we put out there. And here we are, yes. You suspect that the patient may be uncomfortable with the concept of attending therapy, or that she may be experiencing feelings of shame. You suspect that the patient's cultural background may be a contributor to this. Now, remember that these things are multifactorial, and all we can really say from that narrative is it seems that the patient's cultural identity may be a barrier here. That's not a lot of certainty to work with. Because of this, you connect the patient to a therapist that shares her cultural and class background who is available. You also decide with the patient that therapy will be performed via telehealth. So she gets assigned to that therapist and preferred to use telehealth. Now, I put the telehealth in there for a reason. People have a lot of reasons for wanting to use telehealth. And for this patient, say it was something where she didn't want to be seen going to a therapist's office and had some space at work where she could do it. Being able to have shared decision-making in that step is an important part of ensuring continuity of care. Next one, please. So navigating cultural barriers, onto some policies and procedures that we can utilize in our daily lives to navigate these effectively and in the patient's best interest. Next slide. So some key takeaways about navigating cultural barriers based on everything we've reviewed. One, it's important to remember that the impetus to remove cultural barriers in clinical care is coming from you, not from the patient. Cultural barriers take energy to take down, and you need to have the initiative to say that they're there and to do what you need to do to cross them. Even if this is a patient that shares everything demographically with you, realize that there can still be a cultural barrier, and that just the nature of what we do. We are clinicians, and in some ways we speak a different language. And so understanding that that may be a barrier as well. Observe your own practice carefully. Does it appear that members of certain groups are showing up less frequently for follow-ups? Ask yourself why this is happening, and if there are any structural aspects of your institution or care that are contributing to this. If you suspect that there may be a disparity in treatment in your facility, my recommendation is to start a conversation about it as soon as you can. If there does seem like there's a disparity, being able to measure that and to address that is an important part of your facility's mission, I'm almost certain. Okay, yes. So giving a range of options is a really important part of this. And I often think of it like, if I take a friend that doesn't like Nepalese food to a Nepalese restaurant, I'm going to pick one that has a lot of things on the menu because there's more options that may be appealing to them. It's a little bit of an oversimplification, but in a way, giving patients an option for care is in some ways like that. The more options you have to be able to offer, the more likely you're going to find something that's going to work. And the shared decision making is an important aspect of that. Now, I've seen shared decision making happen before that's not really shared decision making. It's sort of a pushing of a patient in one direction. It's important in that we bring them along for each step of the way and include them in all of the changes or alterations to their care. Shared decision making is not really just an approach, it's an entire process. And it should be baked into your facility's guidelines. If it's not, consider bringing it up. Cultural brokers and specialized supervisors are extremely important for crossing these barriers. And they don't necessarily need to be clinicians. Just having someone at the front desk who is from a cultural background that's common in your community and speaks a different language may be an opportunity to start making the connection from and start traversing those barriers the minute the patient comes through the door. Next. So strategies for navigating barriers. Please take the opportunity to share some of your strategies and takeaways with your colleagues. So I want to take 3 minutes here. What I would love to hear is what have you guys done? We'll call these promising practices. What are things that you have done or your facility's done with the goal of becoming more culturally competent or serving a disparate group within your service area? And what are some ways that you integrate cultural competency into your practice or role? Even if you don't see patients. Thank you. We'll take 3 minutes, Fide, if you could take it. Thank you. And Fide, we're cutting close. Do you think we could start, please?
Okay, so do we have any volunteers that they would like to share their experiences, their strategies?
And we don't need to pick for this. If there's genuinely none, there's genuinely none. But I would really love to hear from you guys.
I can share what we did. We don't at this facility right now because it's a smaller one, but I worked for the county indigent program here. So we had a lot of cultural diversity trainings. So that was really helpful. It really helped us see. And also we, when I worked there, they had the translators, not just the multilingual individual. We had the individuals from the countries. And so that would also help because the person would see that person from their country and it helped them be more receptive to whatever it was, whether it be the screening, the medical care. So that's what we did there. Right now at this facility, we're not able to do that yet. Hopefully we can in the future.
I appreciate that. I think it's important to remember that this is kind of like a muscle you need to work out. Diversity training and refreshers, even though you may not think you're learning things when you're hearing them, hearing these messages and interacting with this material does help you to integrate that more into your thought process. And that's a pretty important aspect of being effective at crossing those barriers. Fide, it's yours.
Thank you so much, Anna. We have the raised hand from Kiona. Kiona?
Okay, so I work for a housing authority. And so for us, we also have like trainings and stuff that we do where sometimes it's classes for specific things because we deal with a lot of low income and all that. So we also need training for learning how to deal with people with certain mental disabilities, those who are hoarders, and then also having the options for because everything's going to digital and they're wanting people to do everything online now. Well, a lot of people, because I'm the Housing Choice Voucher Program Manager, so I'm over that, which most people, when they fill out an application, they're used to giving paper applications, but now they're wanting everyone to do everything online. And a lot of people who are on fixed income are elderly. A lot of them don't have email addresses, and some of them don't have access to computers or know how to use the computer. So we also think about that anytime we do anything, also have the option available for reasonable accommodations for anything you might need. If we need translators for when we have meetings or anything like that, we have all that available. I have people with reasonable accommodations where they need to be always meeting in person, or there's some people where they need all their communication to be written. It's like stuff like that. Cause like, not a lot of people, when they think about culture, they automatically think about like ethnicities and stuff like that. But there's also like subcultures and stuff, which also when you have to fill out your annual paperwork every year, they have to recertify. There are some people, because of their status, some people are illiterate and things like that. So we have to remember and keep that in mind when we ask people or we send out paperwork and do things like that. To remember there is a mixture of folks in all the cases that we handle here.
Mhm.
You know, you brought up actually a ton of good things there. Those situations where, and this is one I don't know how to navigate, and I've been in a couple of times when a patient is illiterate and you think they may be, how is there a way to give them a space to get access to another resource or act another resource, which without inciting any feelings of shame or something like that. That's something I've struggled with only really when practicing abroad, but that's a tough one. If you find something out, let me know. Because
Yeah. Most of those cases, they won't come right out and tell you that they can't read or anything. So we always, whenever we give out paperwork or anything, or someone's talking, we're like, and if you need help with filling anything out, just let us know and we can help you out. And there's help available, give them the number or whatever. So then people feel a little bit better if they just ask you, can you help me with this? Versus, especially if we're giving one of our briefings where there's maybe 10 other people in the room with them, they're not going to want to speak up. So.
That's a good point. Making it a safe space where they can actually walk in. And it's when you were talking about the elderly patients, yeah, that's a huge barrier. That's, in fact, it's hard to think of a barrier that's more significant because it's accessing the services at all. That's a population where at times it can be really difficult to understand their perspective because of the ways that their lives are limited. And that's something we need to put effort into. But when you do have that perspective, it allows you to pick these things up. It's like you carry a little voice in your head that tells you, wait a minute, that might be difficult for this patient population, or wait a minute, this might be a barrier for this patient. Listen to the voices is what I've learned. So with that, we're at 2:01. I want to thank you guys all for your honesty and openness with this. These are tough topics, and these are tough jobs. The only way we really get better is by talking through them, understanding them better, and by having the appropriate focus on improving ourselves as clinicians, as administrators, and as professionals in this field. So really appreciate all of you, what you do and the service to your communities, and encourage you to reach out to me if there's any way that I can enlighten or enrich your life. Please don't be shy.
Thank you so much, Kevin, and everybody else also. This is just a reminder to please complete our post-evaluation survey. And in the survey, you're going to find some questions about all the sessions. If you can just provide your honest feedback, we will really appreciate that. And this is our contact information. If you have any follow-up questions, you can contact us here. And that is it for today. Thank you.
Thank you, Shide. Thank you, Kevin. Thanks,
You're welcome.
everybody.
Thank you. Bye-bye.
I took a lot from this. Thank you all. Thank you all.